Hi friends, today I will talk about snake bite management in India, a guide for doctors and paramedics. I have divided this topic into two parts. In first part, I will be discussing the epidemiology, prevalence of snake bite in India, various types of snake bites, poisonous, non-poisonous, various first aid or preventive measures before reaching the hospital, and in the second part I will be discussing about the management part, especially with reference to anti-snake venom and management of various complications of the snake bite. First is the disclaimer. This video is made for educational purpose only, and there is no endorsement for any brand or a company. Friends, snake bite is a acute life threatening time limited medical emergency. It is a preventable public health hazard. About 2000 species of snakes are found in the world, and 300 species are found in India, and out of which only 52 are poisonous or venomous. Commonest type of snake bite is from the Russell's viper, which is followed by humped nose viper, cobra, crate, and cat snake. The commonest site is the paddy field, which is followed by the home and road. Friends, snakebite is a hidden public health crisis. Mostly the rural areas are affected in tropical and the subtropical countries. Most of the cases are underreported. Only approximately 7% of snakebite deaths are officially recorded. India has the highest number of snakebite deaths, approximately 45,900 annually. Most deaths occur in rural areas, and that too in males within the age group of 15 to 29 years. Common crates, they account for 65.7%, and it is a leading cause of snake bite deaths in India. Delayed hospital treatment, lack of antivenom supply, inadequate training, non-standardized treatment protocol, they all contribute to high fatality rates and poses a major challenges in the snake bite management. That's why standard treatment guidelines are urgently needed to address the public health crisis. Three important states with the highest number of snake bite deaths in India are Uttar Pradesh, Andhra Pradesh, Bihar, Tamil Nadu, West Bengal, Maharashtra, and Kerala. There are other high risk states. Important three are Uttar Pradesh, Andhra Pradesh, and Bihar. Why India matters? Because India accounts for a significant proportion of global snake bite cases throughout the world. Underreporting of the snake bite deaths in India means a global total may be underestimated. Friends, mostly three major families of poisonous snakes are found in India, and these are Elapidae, Viperidae, and Hydrophidae family. They have few identification characteristics. Elapidae family includes cobras, crate, coral snakes. Their head has a similar width to that of their neck. They have large scales on the head, no loreal shields. They have round pupils. They are oviparous. They have a short fixed fangs. The vipers of the Viperidae family, they have a triangular head which is wider than neck. They have loreal sheets. They have vertically elliptical pupils. They have long movable fangs. They have pit organs to detect warm-blooded prey. Hydrophidae, that is sea snakes, have small head, flattened tail, and found near the sea coast. They are venomous but are rare biters. Among biting patterns, the creates, they are active during the night hours. They often bite a person while he is sleeping on the floor or bed. Vipers and the cobra bites occurs mostly during the day or the early darkness, when the person is watering the plantation or walking barefoot in the grass or the soybean crops. The poisonous snakes in India, like common cobras, common kraits, saw-scaled viper, Russell vipers. Common cobras, they usually produce neurotoxin venom. Kraits, they produce neurotoxin venom, but there at times they may produce hemotoxic venom also. Saw-scaled vipers, they usually produce hemotoxic venom. Russell vipers venom is hemotoxic, and at times it has a neurotoxic features also. These are the big four snakes which are very poisonous, like Indian cobra, saw-scaled viper, common krait, and Russell viper. The cobras in India are called nag. These are the kraits of India. These are the vipers of India. They are also called doboya or kodia snakes. These are the non-venomous snakes like green vine snakes, dhaman, rat snake, dendu snake, or cat snake. Though they are non-venomous, but at times it is very difficult to differentiate them from the venomous snakes. Standard treatment guidelines, they cover everything: how to recognize a snake bite, how to do first aid and get the person to the hospital, how to diagnose a snake bite, and what kind of treatment is to be given, including the use of antivenom. Different kinds of complication that can happen because of snake bites are also given in the guidelines how to tackle them. Management of these complications in different healthcare settings and basic healthcare centers to more advanced hospitals. These guidelines are meant for all kind of the people, including pregnant women, children, but they don't go in detail about certain serious complication, like when the patient is in shock, have blood clotting problems, when they have renal failure, or those patients who require intensive care. They also don't cover how to manage long-term complication that can happen after the snake bite. These guidelines were developed by the expert groups considered draft national guidelines, WHO 2010 guidelines, Asian and African guidelines. Most recommendations were accepted, but with a key change. That key change included, instead of identifying the snake species guidelines, they focused mostly on the symptom based treatment, that is, syndromic approach. Reason for this change was catching and identifying the snake can be dangerous and it can delay medical care. Identifying the snakes requires specialized skill, which is usually not available at healthcare levels. Bite marks and symptoms may not accurately indicate the snake species. Symptoms of envenomation can develop or can overlap between the species. The various recommendations were how to define the snake bite symptoms. Some people may experience severe symptoms even if they haven't been bitten or haven't received venom. Fear and anxiety can cause symptoms like numbness or tingling in the hand and feet, dizziness, fainting, rapid heartbeat. The severity of the symptoms varies depending on the age and size of the person, species of the snake, number and the location of the bites, amount and toxicity of the venom. Children and elderly are more at risk, and other factors can affect the severity of the symptoms. The factors which contribute to the severity and the outcome in the snake bites are size of the victim. Bigger the size, good is the outcome due to less amount of the toxin per kg of the body weight. Children receive larger anomation related to the body size. Various comorbid condition predisposes to harmful effect of the snake venom. Elderly victim, they succumb more easily to snake venom. Old age, anemia, hypertension, diabetes, renal disease, they poses more danger to the harmful effects of the snake venom. Part bitten, patient bitten on the trunk, face, directly into the bloodstream have a worse prognosis. Exercising or exertion following the snake bite has a poor outcome due to enhanced systemic absorption of the toxin or the venom. Individual sensitivity of the person to venom, atopy or previous sensitization modifies the clinical pictures. Bite characteristics, bite number, depth of the bite, dry bite, bite through the clothes, shoes, or other protection, amount of the venom injected, condition of the fangs, duration for which the snake clinches to the victim, all affect the outcome. Snake species, different species have different lethal dose, lethal period, and aggressiveness. Secondary infection, presence or absence of secondary infection, presence or absence of pathological or pathogenic organism in the mouth of the snake also contribute to or affect the clinical course. Treatment, the nature of the first aid given and time elapsed before the first dose of the antivenom factors. Sorry, nature of the first aid given and the time elapsed before the first dose of antivenom also affects the course of the disease. Factors which doesn't contribute to the outcome are the size of the snake and the time of the bite, that is day or night. Stages of the management of as per WHO are first aid treatment, transport to the hospital, rapid clinical assessment and resuscitation, investigation and lab test, clinical assessment and species diagnosis if possible, antivenom treatment, observing the response to the antivenom, deciding whether further dose of antivenom are needed, supportive and ancillary treatment, treatment of the bitten part, follow-up and rehabilitation. First aid treatment guidelines by the bystander or the victim himself. The principle of the first aid treatment is carried out immediately or very soon after the bite before the patient reaches a dispensary or the hospital. It can be performed by the snake bite victim himself or herself or by anyone else who is present and able to do so. The aim of the first aid is to retard the systemic absorption of the venom, preserve the life, control the distressing or the dangerous early symptom of envenoming, envenoming, arrange the transport of the patient to a place where they can receive medical care. Above all, the aim is to do no harm, provide first aid measure, supportive measure, immediately observe for signs of envenomation, administer ASV therapy as soon as possible whenever there is evidence of envenomation. At a community or village level, check the history of the snake bite, look for obvious evidence of bite like fang, puncture, marks, bleeding, swelling of the bitten part, etc. In crate bite, no local marks may be seen and it can be noted by magnifying lens as a pinhead or bleeding spot with surrounding rash. Reassure the patient as 70% of the snake bites are non venomous. Immobilize the limb in the same way as the fractured limb. Use bandage or cloth to hold the splint like wooden stick, but do not block the blood supply or apply pressure. Ideally, the patient should lie in a recovery position or prone or in the left side with his her airway protected to minimize the risk of aspiration or vomiting. Keep the patient nil by mouth till the victim reaches the medical health facility. Traditional remedies, they don't have any proven effect in treating the snake bite. Ship the victim to the nearest health facility immediately. Arrange the transport to the patient like a ambulance, boat, bicycle, motorbike, stretcher, etc. Victim must not run or drive himself to reach the health facility. Motorbike ambulance may be a feasible alternative for rural India. If possible, PSC medical officer should accompany the patient to know the progress and management and facilitate resuscitation on the way. Inform the doctor of any symptoms such as progress of swelling, ptosis, or new symptom that may manifest on the way to the hospital. Remove the shoes, rings, watches, jewelry, and tight clothing from the bitten area as they can act as a tourniquet when swelling occurs. Leave the blisters undisturbed. No time should be wasted in attempting to kill or capture the snake because it will just cause the wastage of time. However, if the snake has already been killed, it should be taken with the patient to the dispensary or the hospital for the identification by the doctor. However, do not handle the snake with your bare hand, even a severed head can bite. If the victim is expected to reach the hospital in more than 30 minutes but less than 3 hours, crepe bandage may be applied by a qualified medical professional till the patient is shifted to the hospital. The bandage is wrapped over the bitten area as well as the entire limb with the limb placed in a splint. It should be capable of admitting a finger beneath. Traditional methods should be discarded. The important don'ts in management of snake bites are: do not attempt to kill us or catch the snake. Take the picture of the snake for identification by an expert. Discard traditional first aid methods like blackstone or scarification or alternative medical or herbal therapy as they have no role or as they cause more harm than good by delaying the treatment. Do not wash wound and interfere with the bite wound because incision, suction, rubbing, tattooing, cleaning, massaging, cryotherapy, chemicals, cautery, all they introduce infection and they increase the absorption of the venom and increases the local bleeding. Do not apply or inject anti-snake venom locally. Avoid tight tourniquets. The use of tight tourniquets made of rope, belt, string should be avoided as it can cause ischemia or gangrenous limb. Witch crafting should be avoided. Tourniquets are not effective in stopping the venom flow. They can cause harm. They can lead to false security and so delaying medical attention. Incorrectly tied tourniquets can cause ischemia, necrosis, and gangrene. Medical professionals should not apply tourniquets except in specific cases. Gray bandage can be used by the medical personnel to immobilize the limb until hospitalization. Electrical therapy, cryotherapy as used in past are not effective and they can cause harm to the patient. Transport to the hospital, reassurance and immobilization are important. Reassure the victim because victims of the snake bite are very anxious. We have to immobilize the limb, avoid any interference at the bite site. This I have already discussed that what are the precautions to be taken while shifting the patient to the hospital. Instruction while referring inform the need for referral to the patient and caregiver, family member or accompanying attendant. Give prior intimation to the receiving center using available communication facilities. Arrange for an ambulance. Transport in an ambulance equipped with transport ventilator. If the ventilator is not available, tight fitting face mask connected to anesthetic or ambu bag should be available. However, do not waste time to get an ideal ambulance. Motorbike is a practical alternative in rural areas for rapid transport, but third person must sit behind the patient to support him on the bike. If ESV is not available at the first contact center, transfer to the nearest health facility where ASV is available, confirming by the telephone. Transport to a higher health facility, that is a secondary care hospital or tertiary care hospital, where mechanical ventilator and dialysis facilities are available for dialysis and ventilation if required after completion of ASV infusion. During transfer, continuous life supporting measurements, insert nasogastric tube, provide airway support with the help of accompanying staff if required. Send the referral note with details of the treatment given, clearly mentioning the clinical status at the time of the referral. So, this is a flow chart. Whenever there is a suspected case of a snake bite, look for the overt sign or occult bite. Overt bite is it asks for the history of bite. If there is, because 70% of the bites are non-venomous and only 30% of the venomous. And non-venomous snake bites are usually asymptomatic, but patient may have anxiety, palpitation, tachycardia, paresthesias, and 30% bites are venomous, and at times they are dry bites also, that can also lead to patient with anxiety, palpitation, tachycardia, and paresthesias. But 30 among 30%, the symptomatic bites, they can have progressive painful swelling, neuroparalytic symptoms, and vasculotoxic symptoms or myotoxic symptoms. These are all symptoms I'll be discussing in my further slides. So if patient has these types of symptoms, and there will be requirement of the anti-snake venom. So at healthcare facility, we have a diagnostic phase. We have to properly take the history and ask for the symptoms, examine the bite site, look for fang marks or any signs of local envenomation. Fang marks or their patterns have no role to determine whether biting species was a venomous or non-venomous, or the amount of venom injected, severity of the systemic poisoning, and nature of the poisoning. Some species like crate may not leave any bite marks. Signs and symptoms of snake bite. Patient can present as asymptomatic when he has a non-venomous bite or dry bite. Many patients will appear to be asymptomatic if the bite is from non-venomous species. As we know that 70% of the snake bites are from non-venomous species. If the bite is from the venomous species but the venom has not injected through the enough to cause symptoms, or has injected none at all, that is dry bites. The venom is of sufficiently high level to cause symptoms but is now progressing through the tissue without causing swelling to indicate its presence. For example, envomation can take many hours to present sign and symptom, very common in crate bite. Crate bite symptoms can take long time to appear. The victim may be envenomed, but no visible signs are immediately detectable. Symptoms are visible. The victim may have incoagulable blood or bleeding or renal failure, may be underway but not visible. Patient many a times presents with non-specific symptoms related to anxiety. Common symptoms in these patients are palpitation, sweating, tremors, tachycardia, tachypnea, elevated blood pressure, cold extremities, paresthesia. These patients may have a dilated pupil suggestive of sympathetic overactivity. Dry bites, these are by the non-venomous snakes, are common, but bites by the venomous snakes are also not always accompanied by the injection of the venom. That is called dry bites. The presence of dry bites ranges from 10 to 80% of the various poisonous snakes. The symptomatic patient may have neuroparalytic or progressive weakness. It is seen with Elapidae family. Neuroparalytic snake bites patient present with typical symptoms within 30 minutes to 6 hours in case of cobra bite, and 6 to 24 hours for crate bite. However, the toxins in crate bite have been recorded as at least 36 hours after hospitalization. These symptoms can be remembered as 5 Ds and 2 Ps. 5 Ds are dyspnea, dysphonia, dysarthria, diplopia, dysphagia, and 2 Ps are ptosis and paralysis. In chronological order of appearance of the symptoms, furrowing of the forehead, ptosis, that is drooping of the eyelids, occur first, followed by the diplopia, that is double vision, then dysarthria, speech difficulty, then dysphonia, means speech otherwise becomes less, followed by the dyspnea, that is breathlessness, and dysphagia means inability to swallow. This is the chronological order of the appearance of the symptoms, and all these symptoms are related to third, fourth, and sixth and lower cranial nerve paralysis. Finally, the paralysis of the intercostal and the skeletal muscles can occur in descending manners. Other signs of impending respiratory failures are diminished or absent deep tendon reflexes and head lag. Additional features like stridor ataxia may be seen. Associated hypertension and tachycardia may be present due to hypoxia. These are the few pictures. The patients with neuroparalytic snake bite showing the ptosis, conjunctival stuffiness, gum bleeding in viper bite, drooping of the eyelids, that is ptosis, local tissue swelling, and necrosis. How to identify the impending respiratory failure? We do single breath count, that is the number of digits counted in one exhalation, and normally it should be more than 30. Breath holding time, breath holding in inspiration, normal value is more than 45 seconds. Ability to complete one sentence in one breath. If any of these is affected, that it is likely that patient has started developing the signs and symptoms of the involution. Cry of the child, whether loud or husky, can help in identifying the impending respiratory failure. Bilateral, dilated, poorly or non-reacting pupil is not the sign of brain death in elapid envenoming. Envenoming, sorry. Vasculotoxic or hematotoxic snake bites are due to the viper species. They can have local manifestation as well as systemic manifestation. Local manifestations are more prominent in Russell viper bite, followed by the saw-scaled vipers, and they are least in pit viper bites. Local swelling, bleeding, blistering, and necrosis, pain at the bite site, and severe swelling lead to compartment syndrome. Tender enlargement of the local draining lymph node is also seen. Systemic manifestations with the vasculotoxic snake bites is the gingival bleed, epistaxis, ecchymotic patches, vomiting, hematemesis, hemoptysis, bleeding per rectum, subconjunctival hemorrhage, continuous bleeding from the bite side. Bleeding or ecchymosis at the injection site is a common finding in the viper bites. The skin and mucous membrane may show evidence of petechiae, purpura, ecchymosis, blebs, and gangrene. Acute abdominal tenderness may suggest gastrointestinal or retroperitoneal bleeding. Lateralizing, lateralizing neurological symptoms such as asymmetrical pupil may be indicative of intracranial bleed. Consumption coagulopathy is detected by 20-minute whole blood clotting time. It develops as early as within 30 minutes from the time of the bite but can be delayed. These are the few pictures which show uh, like leg swelling, bite marks, and these are local features of the vasculotoxic or hematotoxic snake bites. Painful progressive swelling is indicative of a local venom toxicity. It is prominent in Russell viper bite, saw-scaled viper bite, and cobra bite. This is associated with local necrosis, which often has a rancid smell. Limb is swollen and the skin is tart and shiny, blistering with reddish black fluid at and around the bite site. Skip lesion around the main lesion are also seen. Ecchymosis due to venom action destroying the blood vessel wall can be seen. Significant painful swelling potentially involving the whole limb and extending into the trunk. Compartment syndrome can also be present invariably. Original tender enlarged lymphadenopathy is a common finding. Myotoxics or myotoxic presentation is seen with a sea snake bite. Patient may present with muscle aches, muscle swelling, involuntary contraction of the muscle, sharp initial prick sensation. After that, patient may have painless stiffness in the muscles of the back, neck, and proximal part of the limbs in the 1 hour. Passage of the dark brown urine, compartment syndrome, cardiac arrhythmias due to hyperkalemia, acute kidney injury due to myoglobinuria, and subtle neuroparalytic signs. Occult snake bite is usually seen with great great bite victims often present in the early morning with paralysis or with no local signs. Great has a nocturnal habitat. It has a fine slender teeth, hence the bite marks usually cannot be identified even on the close examination. We have to use that magnifying glass. Typical presenting history is that the patient was healthy at night, in the morning gets up with severe epigastric or umbilical pain, with the vomiting persisting for 3 to 4 hours, followed by the typical neuroparalytic symptoms within the next 4 to 6 hours. There is no history of snake bite, unexplained respiratory distress in children, in the presence of ptosis or a sudden onset of acute flaccid paralysis in a child, for example, locked-in syndrome, are highly suspicious symptoms in endemic areas, particularly of the great white envenomation. Sometimes patient may present with throat pain or chest pain also. Early warning symptoms of the acute pain abdomen with or without neuroparalysis can be mistaken for acute appendicitis, acute abdomen, stroke, Guillain-Barré syndrome, myasthenia gravis, and hysteria. Great white envenoming is diagnosed by developing descending neuroparalysis, while Guillain-Barré syndrome is corrected by the ascending paralysis. Strong clinical suspicion and careful examination can avoid the costly and unnecessary investigations such as CT scan, MRI, nerve conduction studies, CSF studies, and many others, but also help in avoiding the undue delay in initiating a specific treatment with ESV. Atropine neostigmine test helps to rule out myasthenia gravis. Is snake identification important? Don't delay treatment waiting for the snake identification. Snake identification can be difficult or misleading. Even if the snake is seen, its description might not be accurate. Treatment should focus on patient symptom, not the snake species. However, knowing the snake species can be helpful. If the snake is brought as evidence, it can aid in identification. This can help administer species specific antivenom, but this is not available in India. Examining the bite site can also give clues about the snake species. Different snakes cause different local effects, such as cobra causes swelling, bleeding, blistering, necrosis. Crate has a minimal local changes, abdominal pain, hyperperistalsis is seen. Nilgiri Russell viper cause local bleeding. At time of presentation, patient can be critical or non-critical. If the patient comes critical, the patient assessment has to be done on arrival. Rapid primary clinical assessment and resuscitation. Look for signs and symptoms of poisoning at some point in time, and it is not necessarily current, which may not be detected. They are not in themselves criteria for administering the ESV. Rapid primary clinical assessment and resuscitation include CABDE approach. C is circulation, airway, breathing, disability of the nervous system, that is level of consciousness, exposure and environmental control, that is protect from the cold. Airway patency, respiratory movements, arterial pulse, and level of consciousness must be checked immediately. Patient should be intubated if possible or provided with the airway support and ventilated with a resuscitation bag. However, the Glasgow, Glasgow coma scale cannot be used to assess the level of consciousness of the patient paralyzed by the neurotoxic venoms. Urgent intervention is required in the situation when there is profound hypotension and shock resulting from the direct cardiovascular effect of the venom or secondary effects such as hypovolemia, release of inflammatory vasoactive mediators, hemorrhagic shock, or rarely primary anaphylaxis induced by the venom itself. Terminal respiratory failure from progressive neurotoxic envenoming that has led to the paralysis of the respiratory muscle, sudden deterioration or rapid development of the severe systemic envenoming followed by the release of tight tourniquet or compression bandage. Cardiac arrest precipitated by hyperkalemia resulting from skeletal muscle breakdown, that is rhabdomyolysis, after the bite by the sea snakes, certain kraits and Russell viper. If the patient arrives late, late results of the severe envenoming such as renal failure and septicemia complicating the local necrosis. Remember, if the patient experiences respiratory failure before reaching the hospital, they may still recover fully. This information is crucial for the staff managing the mechanical ventilation. Patient with neurological envenomation may require prolonged ventilation to recover. In developing countries, the ventilators are often scarce, leading to a tendency to ventilate patient for a short period only. This can be disastrous, and especially in cases of presynaptic envenoming, physician must investigate the timeline of the respiratory arrest and inform the ventilation staff of the likely outcome. Patient with vascular toxicity, that is bleeding, hypotension, reduced urine output, needs urgent ICU care. Patient with neuroparalytic symptoms like respiratory paralysis, abnormal breathing, they require immediate ventilatory management. Patient assessment, if that is a non-critical arrival or critical patient after stabilization. Keep the patient under observation for at least 24 hours. Ask questions about the bite such as what was the victim doing when bitten, what time did bite occur? What symptoms have he developed since the bite? Look for signs of local poisoning such as fang marks, swelling. Note that bite marks don't always identify the snake species or venomous status. Determining the exact time of the bite to understand symptoms progression. Ask about the urine output and the color as well as any bleeding or bruising. Check for neurotoxic symptoms like sleepiness, blurred vision, or muscle stiffness. If possible, identify the snakes responsible and bring it to the hospital for correct identification. Ask about any traditional medicine used as they can cause confusion or harm. Take a brief medical history including tetanus immunization, medication, systemic diseases, and allergies. Early clues the patient has a severe envenoming. Snake identification as a very if snake identified as a very dangerous one, a rapid early extension of the local swelling from the site of the bite, early tender enlarged local lymph nodes indicating the spread of the venom in lymphatic system, early systemic symptoms, collapse, nausea, vomiting, diarrhea, severe headache, heaviness of the eyelids, inappropriate drowsiness, early ptosis or ophthalmoplegia, early spontaneous systemic bleeding, passage of dark brown or black urine. All these clues shows that a patient has a severe envenoming. Handling the tourniquet. When removing the tight tourniquets, be cautious to avoid a sudden surge of venom. Check for the pulse distal to the tourniquet before removal. If the pulse is absent, ensure the doctor is present before removal. Remove the tourniquet only after administering the ESV in the presence of a doctor. Physical examination. Assess the bite site, signs of the local envenomation. Monitor patient closely and repeat the examination every 1 to 2 hours. Check vital signs like pulse rate, respiratory rate, blood pressure. Perform 20-minute whole blood clotting time every hour for the first 3 hours and every 4 hours for the remaining 24 hours. Compartment syndrome. Monitor for signs, pain on passive movement, pallor, pulseless limb, hyposthesias. Measure compartment pressure directly if concerned. Diagnosis. Establish if the pressure is above 40 centimeter, water or saline. Direct measurement is necessary before resorting to a fasciotomy. Remember, the compartment syndrome is rare in snakebite victims, but fasciotomy without correcting the hemostatic abnormality can lead to fatal bleeding. Clues for severe snake information. Rapid swelling around the bite site, enlarged and tender lymph node, neurological symptoms like drooping of the eyelids, muscle weakness, respiratory distress, spontaneous bleeding from the gums, bite site, blood in the urine, coughing of blood, that is hemoptysis, epistaxis, ecchymosis, unconscious with or without respiratory assist, dark brown identification of the highly venomous snake, that is cobra, Russell viper. This I have already discussed in my previous slide. Physical examination of the bitten area. Check for swelling and tenderness. Examine the lymph node. Look for bruising, redness, or lines indicating the lymphangitis. Bitten limb. Check for swelling, coldness, immobility, or absent pulses. Measure the compartment pressure. Signs of necrosis like blistering, darkening, or paleness of the skin. Loss of sensation. Smell of the rotting flesh. General examination. Check for blood pressure, heart rate. Examine the skin and mucous membrane for bleeding and bruising. Check gum for bleeding. Examine nose for bleeding. Check abdomen for tenderness. Check back of for tenderness. Russell viper bites. Check for neurological signs, convulsion, impaired consciousness. Remember to examine the patient carefully and thoroughly to identify any signs of envenoming or complication. Coming to the diagnosis phase, 20 minutes whenever the patient of suspected or snake bite comes to us, always do a 20-minute whole blood clotting time. Collect a 2 to 3 ml of fresh venous blood in a new, clean and dry glass vessel or tube. Leave it at room temperature for 20 minutes without disturbing it. Gently tilt the vessel to check if the blood has clotted. If the blood has clotted, the test is passed and no antivenom is needed at that stage. Repeat the test every hour for the first 3 hours, then every 6 hours for 24 hours until the test result is non-clotting or there are signs of envenoming. If the test is non-clotting, repeat after 6 hours of administering the loading dose of ESV. In case of neurotoxic inflammation, repeat the clotting test after 6 hours. If the blood is still liquid, incoagulable blood that shows hypofibrinogenemia, normal whole blood clotting time is 6 to 8 minutes. Note that the test should be done in a clean and dry vessel or a tube, and then blood should not be shaken or disturbed during the 20-minute waiting period. According to the literature, the prothrombin time is prolonged if the plasma level of any of the requisite factors are below 10% of the normal and is relatively more sensitive, but CT will be significantly prolonged only in severe deficiencies of the various coagulation factors. So the various investigations which are required at primary health center are peak flow meter in patients, especially the adolescents and adults presenting with the neuroparalytic syndrome. If the peak flow meter is not available in the PSC, then assess the respiratory function using a bedside test like single breath count, breath holding time, and ability to complete one sentence in 1 second. Ability to complete one sentence in one breath, as described earlier. Look for urine for albumin and blood for dipstick method. At district hospital, in addition to the above test, do prothrombin time, platelet count, clot retraction time, LFT, RFT, serum amylase, blood sugar, ECG, abdominal ultrasound, 2D echo if available. The tertiary healthcare center, in addition to the above, do arterial blood gases. Arterial puncture is usually contraindicated in patients with hemostatic abnormalities, and also do the pulmonary function test. In vasculotoxic snake bite, do coagulopathy like BT, CT, PT, APTT, platinum, platelet, serum fibrinogen, FDP, D-dimer, LDH, peripheral blood smear, hemolysis, urine for myoglobin, urine hemoglobin. For renal failure, do the urine microscopy. For RBC, cast, RFT, urine protein creatinine ratio. For hepatic injury, look for LFT, including the SGOT, SGPT, alkaline phosphatase, serum protein. For cardiotoxicity, look for CPK, MB, 2D echo, BNP. For myotoxic snakebite, look for CPK, SGOT, urine myoglobin, compartment syndrome. And for infection, look for serum procalcitonin culture, blood, urine, or wound culture sensitivity. Arterial blood gases and urine examination should be repeated at frequent interval during the acute phase to assess the progressive systemic toxicity. So various interpretation of the test are which are seen in the snake bite are: the hemoglobin level may be high due to dehydration, or it can be low due to hemolysis. Neutrophilic leukocytosis indicates systemic absorption of the venom. Patient may have a thrombocytopenia in viper bites. White blood count, early neutrophil leukocytosis indicates systemic poisoning. Blood film may show fragmented red cells like helmet cell schistocytes, which indicates a microangiopathic hemolysis. Serum creatinine may be raised, and it indicates acute kidney injury. Serum creatinine phosphokinase elevated level may indicate muscle damage. Prothrombin time, activated partial thromboplastin time, that may be increased in viper bites, fibrinogen and fibrin degradation products. Low fibrinogen with elevated FDP indicates venom interfering with the clotting. Urine examination like proteinuria, RBC, hemoglobin urea, myoglobin urea may be present in myotoxic snake bite poisoning or hematotoxic snake bite poisoning. ECG may shows non-specific STT changes and may show bradycardia and AV blocks. Electroencephalogram may show abnormal changes, especially in the temporal lobes. Pulse oximetry is necessary for the patient with respiratory failure or shock. Electrolyte disturbances are necessary for patient with respiratory paralysis and systemic symptoms. ABG may show evidence of respiratory failure and acidemia. So, in nutshell, we may find elevated WBC count when the patient has inflammation. It may be suggestive of infection, inflammation. Hematocrit or HB may be show transient increase or increased capillary permeability because of Russell Viper. It may be low when there is hemolysis. Platelet count may be low in Viper poisoning. Fasting, so peripheral blood may have fragmented RBCs or hemolysis as seen in viper bites. Creatinine kinase may be elevated in sea snake, Russell viper. Normal serum creatinine may be raised in viper and sea snake bite. Hyperkalemia is seen with rhabdomyolysis, especially with the sea snakes. And if patient has a low platelet, prolonged PTA, PTT, microangiopathic hemolytic anemia, fragmented red blood cell in the peripheral blood smear, and hypofibrogenemia, all these features are suggestive of DIC. This is a chart of the coagulation cascade, that how can we come to the diagnosis of a DIC. Some snake bite patient may have late onset features, so we always keep the patient under observation, monitor the patient for at least 24 hours after snake bite. Some snakes like crate and hump nosed pit viper can cause delayed symptoms. Symptom can take 6 to 12 or even longer to appear. Late onset envenoming is common, especially in the common crate bite. Juvenile snake bites can occur, or they can take longer to show symptoms, and they tend to bite lower on the foot. It is important to keep the patient under observation for a longer period to catch any potential delayed symptoms. These are the few features of the various snake bite cases. Like local pain and tissue damage is seen in cobra, not seen in the crate poisoning. It can be seen in Russell viper, saw-scaled viper, and hump-nosed viper bites. Ptosis and neurological signs are seen in cobra, crate, and Russell viper. They are not seen in saw-scaled viper and hump-nosed viper bites. Hemostatic abnormalities are seen in the Russell viper, saw-scaled viper, and hump-nosed viper, but they are not seen in the cobras and the great bites. Renal complications are very common in Russell viper and hump-nosed viper bites, but they are not seen in the cobra, crate, and saw-scaled viper. Patient can show response to neostigmine in only in cobra bite cases. Response to ASV is seen in all bite except the hump-nosed viper bite cases. This was all about the part 1 of the snake bite management. In next part 2, I will be discussing the management at the hospital level, especially with reference to the use of anti-snake venom, various complications of the snake bite, and its management. Thomas Sydenham has said, medicine is not merely a science but an art. It does not consist merely in the application of the remedies, but in the exercise of a peculiar skill which can be acquired only by experience and observation. With this, I conclude my part 1 of the snake bite management. See you in the part 2. Thank you very much.